and tibia. And it's interesting, this doesn't get a lot of press. I don't remember a whole lot of it in my residency. And this was in JBJS last year. That these concepts are really still not mainstream for some reason, and they're not really a big part of residency education either. Yet, most of you are going to deal with this in some way or another, whether you go into sports and think you're going to do an ACL on someone that may have a deformity in their knee, or in pediatrics certainly deals with deformity. We deal with it in trauma, and then that's sort of the joint replacement surgeon's job, is to correct deformity. So you're going to see these topics over and over again, and so I'd like to go through them in some detail, with the objective being really understanding how to evaluate the deformity. That's the primary goal of this talk, and to understand it's sort of its own language when you're talking about deformity in the lower extremity, and then to recognize some of the treatment options and factors for treatment. So malunion, this is generally where I deal with deformity. It's a fully healed fracture with any deformity. It can be in a multitude of directions and planes, but what we're really interested in is a clinically significant malunion, and that leads to either soft tissue or joint dysfunction or some sort of gait disturbance. So the first thing to do is to figure out why that patient is there. What are they complaining about? Is the deformity even symptomatic, or is it going to cause them a problem long term? And so most of the time, patients will note some sort of perceived deformity or alteration in cosmesis. They may say their leg feels rotated funny, or they're tripping over their foot, or they have pain in their knee or ankle or hip, for example. And then certainly if you think they have a healed bone, if they have pain, that's a warning sign for another problem like an infection or a non-union. This is one of the times where, I don't do a lot of detailed histories, but this is the time where you really need a detailed history about what's been done, who all has touched that leg, has it been fractured in the past, was there previous surgeries, previous flaps, do they have good blood flow, do they have neuropathy in the foot? All of these things are critically important before you make a treatment plan. And then we'll go through the clinical examination and radiographic examination. And I think it's critically important to know if this deformity has changed recently, if they have a progressive deformity that's completely different than if they've had a static deformity for many months or years. So the physical exam, this is similar to any physical exam, but you really want to look closely at the limb, the vascularity, the skin exam, the joint mobility around where the perceived deformity is, and then watch them walk and see how this deformity affects their gait. In terms of physical exam, one of the most important things is the rotation of the limb and the rotation of the bone that's involved. So radiographs are not good at detecting rotational abnormalities. It's sort of up to you to identify that by looking at the patient, examining the patient. And for the femur, the total arc of rotation may be the same, but they may have a different amount of internal rotation of one leg versus the other in terms of the hip. And they may have differences in the trochanteric version. So you can estimate the patient's version by rotating their leg with the knee bent until you feel the maximum trochanteric profile, and that's an estimation of their femoral anteversion. It may be different between sides. Most of us from our peds and adult are familiar with the thigh-foot angle for examining the tibia. I think this is easiest done prone. You can do it supine with the knees bent 90 degrees and compare side-to-side differences. Angulation has multiple effects on the surrounding joints. The joints can either compensate for it, but they also can be significantly affected by a deformity. So in general, as you know, deformities in the plane of joint motion are better tolerated, but that can also alter the joint long-term, particularly the ligaments around the joint and the cartilage if there's profound or prolonged deformity. Here's a common example of that. So this is a patient that has a valgus distal tibia malunion. In order for the foot to get plantigrade, the subtalar joint inverts, and that can lead to a subtalar inversion contracture. So if this is long-standing or severe enough, if you go and correct this tibia, then all of a sudden they can't get their foot into a plantigrade position because they have this contracture. So This is true not just of the subtalar joint of the knee. If they have, for example, if they have a hyperextension distal femur deformity, and you go and correct that, and all of a sudden you unmask a knee flexion contracture, that patient's not going to be very happy. So the test for that is that patient's distal segment should be able to become coplanar with the deformity, or they should be able to get their foot into the deformity is what that's called, and that indicates a supple enough joint that the deformity correction can proceed. In terms of radiographic examination, the standard evaluation is the full-length standing films. This is defined as a knee forward position or a patella forward position if they have a normal patellofemoral joint, and it should really include the hip to the ankle. The pelvis should be leveled. This pelvis has not been leveled in this film, but there should be some blocks under the shorter limb to level the pelvis, and you also want to get an AP and lateral of the affected bone. There'll be times with significant rotational deformity where you need to get a hip forward view of the femur and an ankle forward view of the tibia if they have severe rotational deformity to really map out some of the angles in the lower extremity. Rotational deformity, this is one of the things that for some reason makes it on your in-training exam about every year. It's important to pick up on this, like I said, as the plain radiographs don't always pick up on rotational deformity. CT scanogram can be helpful where you take axial cuts through the hip, knee, and ankle to look at the rotation between the limbs. So let's just focus a little bit on this example and try to understand how to evaluate this so you guys can get this question right on your test. Let's look at the right leg first. That's the left of the two image panes. And so for me, in orthopedics, things are described from the distal segment relative to the proximal segment. So I think it's most helpful to make the hips neutral and then describe the knees relative to the hips. And so if you look at this top left image, which is the right hip, you can see that that hip's about 3 degrees externally rotated. And so in order to make that neutral, you would internally rotate that limb to 3 degrees. That would take the already internally rotated femur to 18 degrees of internal rotation. Does everyone understand that? So this is 18 degrees of internal rotation of the knee relative to the hip, which is also the patient's anteversion. If you do the same thing over here, you look at the left hip. This is 5 degrees of internal rotation. Everybody see that? So in order to make that hip neutral, you would externally rotate that hip 5 degrees, which would make that hip neutral, which would externally rotate the distal segment 5 degrees. So on the left distal femur is externally rotated 5 degrees relative to the hip. So internally rotated 18 on one side, externally rotated 5 on the other. That's a net of 23 degrees of external rotation. So you would internally rotate this distal femur on the left side 23 degrees to correct that deformity. I think that's the easiest way to understand it, for me, is to make the hips sort of neutral. Length is also important. It can contribute, particularly in the femur, to a mechanical axis problem. In my fellowship, we did a lot of these CT scanograms on the right side. We would do AP and laterals and measure bone lengths based on these. You can do it on plain radiographs too. There is some parallax changes depending upon how the hip to knee film is shot, or hip to ankle film, excuse me. There's what's called true and apparent leg length discrepancy. We talk about this some in trauma conference. Apparent leg length discrepancy is not a true length difference in the bones, but it's often related to soft tissue contracture. True leg length discrepancy is the actual bone lengths, and limb lengths are different. So as I said, this deformity analysis is sort of a language of its own, and we need to make sure everyone's on the same page before we start talking about all these terms, defining them first. And so all long bones have an anatomical axis. This is just simply two mid-diaphyseal points connected by a line, and it's defined in the frontal and sagittal planes. And the femur is a little bit interesting because it's curved in the lateral in the sagittal plane, so the anatomic axis is curved in the femur depending on when you use points in the femur. The mechanical axis is simply, as you know, the center of the bone, proximally to the center of the bone distally. We generally use the frontal plane for this. The entire limb also has a mechanical axis from the center of the hip to the center of the knee. generally passes just through or medial to the center of the knee. Joint orientation angles, these are just the angle of a joint line relative to one of those axes, either the mechanical or anatomic axis. It's nice in the tibia because the lines are parallel, so you don't really have to define. The angles are the same, whether you're using the mechanical or anatomic in a normal tibia. And then in the femur, you have to define whether you're using the mechanical or anatomic axis, and you really shouldn't mix anatomic and mechanical axes. The femur in general is a little bit strange. When you're looking at joint orientation angles, you have to define the points that you're using. I think most commonly people are familiar with the lateral distal femoral angle, whether it's anatomic or mechanical, but you have to define how you're going to measure the proximal femur, and so that's typically done in one of two ways, either the center of the femoral head to the tip of the trochanter relative to one of the axis lines, or using the anatomic axis with the axis of the femoral neck to the center of the head. And then there's different ways to do sagittal plane mechanical alignment. You're really just trying to measure fixed relationships. And so in the distal femur, you can see where they measure the lines from the articular edge anteriorly and posteriorly to a anatomic axis. Again, you can use any two fixed oriented lines, and so occasionally in our field it's useful to use Blumenstadt's line relative to either the posterior cortex of the femur or to the shaft of the femur as a fixed angle that we use to determine sagittal rotation, particularly in severely comminuted femurs where we're trying to figure out how to rotate the distal femoral condyles. I think the tibia we're probably all more familiar with. We know there's 9 degrees of posterior slope. So this is the, wrong button. You can see there's also anterior distal slope at the ankle joint too, which is not as commonly talked about as the slope in the proximal tibia. So malalignment and malorientation, it's important to understand the differences and what these terms mean. So malalignment is simply mechanical axis deviation or loss of the collinearity of the ankle, knee, and hip in the frontal plane. And there's really 4 sources that this can come from, either the femur, the tibia, or essentially variations in the knee joint. I think the femur and tibia are pretty self-explanatory. Intrinsic knee joint malalignment, so this can be from arthritis or subluxation of the knee joint, ligamentous laxity. And so this is measured by what's called a joint line congruence angle. So the joint line of the femur and the tibia relative to each other, they should be within 2 degrees of parallel. And then the so-called condylar malalignment, this is probably best thought of as differences in the medial condyle of the femur to the medial condyle of the lateral condyle of the femur, and then the lateral condyle of the tibia to the medial condyle of the tibia. So lateral femoral condyle hypoplasia and intra-articular tibial plateau condyle malalignment can lead to alterations in the joint that affect the mechanical axis. Malorientation simply means the joint, there's no mechanical axis deviation typically from the malorientation, but it's alteration in the position of the hip, knee, or ankle joint. So I think the easiest way to think of this is in joint arthroplasty, you can alter the joint line orientation, but have sort of a compensatory deformity in the femur and tibia. So let's say you cut the tibia into varus and then you cut the femur into valgus. You don't maybe change the alignment, but you change the orientation of the joint, and that alters the forces on the soft tissue. Similarly, if you see the ankle joint as the distal end of this mechanical axis, so you can rotate the ankle to face in varus or valgus, and it doesn't affect the mechanical axis, but it certainly affects the forces across the ankle joint. So Paley, Dror Paley is one of the big names in deformity analysis and correction. He and Kevin Tetzworth defined the malalignment test, and this is done on the full-length standing films to try to determine what are the sources contributing to deformity. And remember, there may be compensatory changes, so you may have a deformity in the tibia and just analyze the tibia, but there may also be arthritis in the knee or some other source that's contributing or compensating for that deformity. So the first thing you do, this is the so-called malalignment test. The first thing you do, of course, is look at the mechanical axis, see if there's deviation. And then two angles, you're going to look at the mechanical lateral distal femoral angle, should be within 85 to 90 degrees. If it's not, the femur is probably contributing in some way to the deformity. You're going to measure the medial proximal tibial angle. Fortunately, it should fall within the same 85 to 90 degrees. If you're outside of that, the tibia is contributing. And then you're going to look at the intrinsic knee joint pathology. And then finally, the bone lengths can contribute to mechanical axis. A word on sagittal plane malalignment. We talk about this a lot less than we do coronal plane alignment. That's because the joints tolerate it better. They can compensate for it. But it's certainly something that we can see and that we do see in trauma, and I'm sure in other fields as well. So flexion malalignment is when the mechanical axis passes behind the center of rotation of the knee joint. And then hyperextension or extension malalignment is when it passes well anterior or more than 5 degrees hyperextension on one side than the other side. So that's a lot of information. I'll let your brain just rest and digest. This is a par 3 that I played in Hawaii a few weeks ago, down towards the ocean, and I hit it in the bunker on the right. I actually took like 4 shots, tried to get Allison to videotape me hitting one on the green, and it didn't happen, so I gave up. So sort of blew through that. That was a review, basically to define malunion, how we look at deformity, how to do a clinical history and physical, and then sort of normal radiographic alignment, normal alignment, and then start to look at malalignment, particularly rotation and length first, because you need to pick up on rotation again off your clinical exam. And so that's kind of your first step. And then we talked a little bit about length. This will be mixed in here a little bit more, but what I really want to get into is sort of the meat of this, which is angulation, translation, analysis, and then treatment. So for angular and translational deformity, the bone has a deformity and there's a defined proximal and distal axis. That's sort of the first thing to know about deformity correction and deformity analysis is there's a proximal anatomic axis and a distal anatomic axis that may or may not cross each other. We'll start with angular deformity. Generally speaking, you don't want to mix mechanical and anatomic axes whenever you're measuring a deformity. And so in this example, it's a diaphyseal deformity. We use the anatomic axis, and you can see the magnitude of this deformity is the angle made by those two lines. It can also be done for using the mechanical axis, and the measurement should be, the magnitude, should be the same. Angular deformity, generally speaking, it's usually a uniapical, meaning one apex of deformity. It can be a multi-apical deformity, and all uniapical deformities are uniplanar. So just because you see the apex on the AP and lateral x-ray doesn't mean that there's more than one apex. It just means that it's not in the plane of the x-ray. It's in a so-called oblique plane. Diaphyseal angular deformity, easy to see, easy to measure, easy to identify. Juxtaarticular deformity, a little harder to see, a little harder to identify, a little harder to see where the apex is. And so there's a few ways to find the apex and to define the short segment. So we talked about joint orientation angles. That's one way. You can use either the contralateral limb. So this is a right leg. You could use the medial proximal tibia angle of a normal patient or of the patient you're examining, and use that to find the proximal axis. And this is the one time where you can use continuation of the mechanical axis of the femur if you need to find the proximal segment axis. And that gives you the magnitude. Cora, this is also something that most people have at least heard of. It's simply the intersection of the proximal and distal axes. And in general, rotation of a pure angular deformity through a cora will lead to a pure angular correction. So the cora is just the intersection point. The cora is actually not just one point, it's actually a line of points or a plane of points through which angular deformity correction can occur. And so the reason this was first sort of described is that in the old Elizaroff frames with hinges, so you'd have imagine a ring here and a ring here, and then rods. This would tell you where to place your hinges to get pure angular correction if you're along that bisector line. So again, the bisector line splits the angle of the deformity in half. This is where we were talking about the oblique plane deformity. So if the apex is not purely in the coronal or sagittal plane, there's a way to figure out its magnitude and also its direction. And I know it's a little crazy to see a squared plus squared square root. I sort of got a little anxious putting this together, but let's look at that a little more closely. It's just the Pythagorean theorem of a triangle. And so let's look at this patient, for example. This is an AP of the tibia. They have 20 degrees apex lateral angulation. Does everyone see that? And then 25 degrees of apex anterior angulation. So if you look at this sort of in the transverse plane, this is the direction of the apex, somewhere this direction. Does everyone agree with that? And so the way to figure that out is they have 25 degrees of anterior angulation, 20 degrees of lateral angulation. And so you just plug this into the Pythagorean theorem, and that magnitude is 32 degrees in that direction. Or we're pretty close to that anyway, within a couple degrees. There's another technique that gives you an exact measurement using tangents, and that's probably above my head. So this is the graphical way to do it. It's very accurate. There will be times when you're doing this where the chora doesn't make sense, particularly in trauma. The chora may not be at the apex of the deformity. You may see an angulation and the chora is not there and think, why is this not at the apex? Or the chora is not even on the bone at all. It's proximal or distal to the bone. Or it's at a different level on the AP and lateral radiograph. These are where it gets a little more confusing. And so in general, that means there's involvement of either more than one apex or translation involved. And so here's a patient with a multi-apical deformity on the left. You can see the chora seems like it's down in the ankle joint. That doesn't make a lot of sense, but there's really two apices. And then there's no chora with apparent chora in the center. And then on the right image, you can see the chora is not where you would think it would be exactly. And so this is when translation gets involved. Let's start with multi-apical deformity. Generally, diaphyseal, again, it's pretty obvious. But if it can also have an apex up near the joint too, or down near the ankle joint. So you should always check with your normal angles. And so in these cases, two choras exist. And there's a third axis line kind of between those two choras. If I'm going too fast or something doesn't make sense, just stop me. So in general, in order to get a pure angular deformity correction with two choras, you need to make two osteotomies. You can correct these with a single osteotomy, but you're going to induce translation. So that's what the diagrams are showing on the top right. Translational deformity. In this case, the axes are parallel but displaced. You can actually break this down into two equal but opposite angular deformities. And again, this is a little blow your mind at first, but a third axis line can be drawn between these two, and two choras actually exist and can be used to describe translational deformity. So therefore, there's two ways you can correct translation. You can do a single osteotomy, translate the bone ends, or you can do a dual osteotomy and dual opening closing wedge, or opposing opening wedge osteotomies to correct translation. And then probably the most confusing to me is this combined translation and angulation. You'll measure angulation the same, so the intersection of the proximal and distal axes, and then you measure from the proximal aspect of the distal segment to measure the translation, and you measure over towards the axis of the proximal segment. So in this deformity, we would come to the proximal aspect of the distal segment here, and then measure across to the axis of the other segment, of the proximal segment. Again, if the translation, you can have translation on one plane and angulation in another plane. And so in that case, the choras are going to be at different levels on the AP and lateral x-rays. All right, there's a lot more information. This is the view off the balcony at the place that I stayed. That's Mauna Kea Mountain. This is on the Big Island of Hawaii. This is, again, Big Island, bottom right. Most people are more familiar with Oahu and Maui. The Big Island is the biggest island. And we stayed up on this coastline. The volcanoes are over on this side. Hilo is basically rainforest, and this is on this side, other than the beautiful beach, has a lot of volcanic rock and black rock. So there's like 7 different climates on that island or something like that, and it's not very big. We drove from one side to the other in about an hour and a half, 2 hours. All right, I think we have the tools now at least to start to talk about correction. All of the corrections go through one of 2 paths, as far as I know. Osteotomy first, and then either acute correction with some kind of fixation or external fixation and gradual correction. So the first step in the path is to figure out which way you're going to go and then come up with a treatment plan. There's pros and cons to each. There's some people that believe gradual correction is the best. The main advantage of gradual correction, anytime you're doing a complex, non-straightforward osteotomy, is you have to deal with that the bone ends may not touch perfectly when you're done. And so you have to decide, if you're going to do an acute correction, can I get these bone ends to touch and heal? And if not, do I need to add bone graft? And so that's the advantage of external fixation and slow correction, is it relies on regenerate formation and bone growth or osteogenesis during the translation. And so you don't necessarily need bone graft. You can cut someone with a severe deformity, gradually correct them, and over time, or as they move, they form new bone, and you don't have to bone graft these people. However, you have to have a patient that is reliable, that is dedicated to that treatment. It's going to make it through maybe 6 months or a year of treatment, and they have to be able to turn their own struts or turn their own device. And I don't know if you've known or met many of our trauma patients, but not all of them can do it. So acute correction is kind of one and done, and we're familiar with plates and nails. How do you do an osteotomy? I don't think this is talked about a lot, but it's important to know. There's a few ways to do it. Certainly you can use an oscillating saw and irrigate. That's one way to do it. I prefer intermittent drilling with irrigation and an osteotome, or a giggly saw. And the giggly saw is probably easiest to use in the tibia. This is, in my fellowship, how we would do it, particularly when you're doing a small wire frame. There's nothing worse than putting on an alizaroff, drilling holes, using an osteotome, and then, well, shit, I didn't quite break it all the way. And now we're trying to move the struts, and it won't move, and so you got to take them back. And so at least with the jiggly saw, when that saw comes all the way through, you sort of know you've cut the bone. And so this is how you do it in the tibia. You make a small incision just lateral to the crest, and a posterior medial incision just off the posterior medial border. You can dissect around with a curved elevator, and then use suture to pass the jiggly saw. The jiggly saw has little loops that go on the handles. You can use suture to pass with a suture passer or a curved clamp, and then pass this around the bone. And then, has everybody used the jiggly saw? Who hasn't used it? So you got to do the 90-degree cutting motion, and then really try not to cut all the way through the skin when it comes through. So that's one potential problem. The real key, though, is you're trying to do as little damage as possible to the bone and soft tissue. You want to do this with low heat, bone preserving, and sort of low energy. Most of you are familiar with these simple osteotomy types, the opening wedge, closing wedge, and neutral wedge. I've sort of drawn these so you can see it. You can see the differing effects. So in general, the opening wedge, if it's done acutely, often requires bone graft. Closing wedge typically does not. In the neutral wedge, you may have some bone you can translate to the other side. Again, remember this concept of the kerf, which I asked you guys about in trauma conference. When you cut with a saw, you're taking away bone. And so woodworking people know this. And so the thickness of your blade, you're taking away that much bone when you cut. So thinner blade is better in terms of not taking away bone. These are the osteotomy rules. These are outlined by Paley. So these just talk about what happens depending on where you cut relative to the chora and where you rotate relative to the chora. And so the first example is the simple example. So if you cut through the chora and rotate through the chora, you get complete realignment without translation. So I tried to draw this in stick figures. And so the black dotted line is the cut. You can see the chora and the correction axis. So again, imagine you're rotating around this blue sort of circle with a star in the middle. That's the correction axis. Okay. So the first rule we talk about, I think people generally understand that. That's generally how people understand chora. And so if you cut outside of the chora, you can still realign the proximal and distal axes without translation, as long as the correction axis is through the chora. But when you do that, the osteotomy itself is going to angulate and translate. So here's the same case. We've now cut above the chora, but the rotation is going to still be through the chora. Does everyone understand that? So we're not rotating up purely at the osteotomy. We're generally rotating down below. And so the proximal and distal axes lines realign, but now you have angulation and translation at the osteotomy. And then the third, if you cut outside of the chora and rotate outside of the chora, you get translation of the axes and angulation and translation through the osteotomy site. So now we've translated the proximal and distal axes, but corrected the angulation. Sometimes that may be beneficial, actually, because this moves the entire axis more than just a pure angular correction. So imagine the ankle's down here and the hip is up here. We've moved the entire axis significantly more, let's say lateral or medial, depending on the angle of deformity. So those are the so-called Paley's osteotomy rules. Just important to understand what you're doing to the bone and to the osteotomy site. So again, we can either treat these acutely or gradually, plate or nail, and there's different types of osteotomies. There's more complex osteotomies. We'll show a couple of those here in a second. Just a quick note on the fibula. Don't hesitate to cut it or to cut it out. And partial fibulectomy is, we use this a fair amount in my fellowship. I think it's more important to do a partial fibulectomy with gradual correction. The trouble is, if the fibula heals before you're done moving the tibia, then you're back in the operating room. So if you're going to do a gradual correction, it's helpful to go ahead and cut out a chunk of the fibula and just not have it be involved in the healing, or at least any restriction to tibial deformity correction. If you're going to do an acute correction, so particularly a valgus to a varus correction, you don't necessarily have to cut a chunk out because you're going to gap the fibula. If you're doing a varus to a valgus correction, it may be helpful to cut out a chunk of the fibula for your overall correction of alignment. And the fibula is kind of a chameleon, as you can see. It bastard will heal sometimes, no matter what. Gradual deformity correction, this could be a lecture in its own. I just want to talk quickly on the basics, and then we'll get into some of the acute correction stuff in some cases. So again, gradual correction, the real benefit is distraction osteogenesis. So if you have a deformity that you're anticipating, man, this is going to end up and the bones are going to be barely touching or not touching when I correct this, this may be a good option rather than trying to rely on a huge bone grafting procedure. Generally tolerated in the tibia, better than the femur, though I've seen it done in the femur. It's a pain in the butt. And remember to cut the fibula or cut it out, a piece of it, 3 centimeter piece. There's what's called a rings first method or a residual deformity method. So the rings first method is kind of the classic way to do this. You make the proximal ring perpendicular to the mechanical axis or to the joint line, and then the distal ring perpendicular to the distal segment axis or joint line. And then over time, as the deformity corrects, the rings become parallel. And that's sort of the elegant, pretty way to do it. In less severe deformities, you can just put on the frame that's already been assembled and been flashed by the operating room or cooked by the operating room. You can just slip that on the leg and attach it to the bone and do a total residual deformity correction with the software. And essentially, you will realign the bones, but the frame will become crooked. And so if you imagine if they have a severe deformity, you can't put a straight frame on that leg. So there's a limit to the residual deformity method depending on how much deformity they have. Tailor spatial frame, essentially you're just telling the computer what the deformity is, what the size of the frame is, and where the frame is relative to the bone. That's it. If you understand how to put in those parameters, the computer, and you select an origin and a corresponding point, the computer can give you a program and a rate to get those points to line up. So in general, you make an osteotomy. The fracture hematoma is allowed to sort of consolidate over a latency period, and then you start a gradual correction. And so this is the other benefit of gradual correction. So imagine you have a patient that has a severe varus deformity, and it's been there for 10 years, and their neurovascular bundle, their tibial nerve, is all contracted, and you're going to correct them a significant amount. They may be short too. It's hard to do that acutely and feel safe about it, so gradual correction, you can set a structure at risk that you want to lengthen over time. And you can stop if they begin to have symptoms and start up again. So most of the sports and joints guys have probably seen an x-ray like this: unicompartmental medial arthritis, varus deformity, sort of the reflexive HTO. And what are you going to do, closing or opening wedge? Well, actually you can do this as well. You can do an osteotomy below the tubercle. This patient is able to weight bear during this treatment. They're able to bend their knee because the proximal rings are not full rings, they're 2/3 rings. And then rather than worrying about bone graft, you simply have distraction osteogenesis and realignment of the mechanical axis. And so the one caveat to this is a little outside of where, if you get this too translated, the joint arthroplasty doctors are going to look at you like, oh boy, what am I going to do with my revision if this primary fails? But certainly there's plenty of bone stock away from that deformity for the surgeon to do a joint replacement standard if needed. So that's an option. This was published by my co-fellow last year in JBJS as an alternative to an HTO with plate and screws. So you can find it in last year's JBJS, this technique, and case series of Brinkers. And that's really the trouble in deformity correction. It's all level 4 evidence, case series. There's not a lot of comparative data except maybe in the HTO literature. But all of these are unique deformities, or for the most part, they're fairly unique deformities in unique patients, and we have sort of case series and case examples. This is probably the more fun stuff to most of you, the acute, let's correct it immediately, and take a crooked leg, make it straight immediately, and fix it. So again, the real question here is, what is the bone contact going to be when you get done? And so this has got to be planned out to try to maximize bone content and figure out if you need to add bone graft. You can do a simple osteotomy. The nice thing about a nail is secondary bone healing can help you. If you're going to use a plate, often you need augmentative bone graft, particularly if it's an opening wedge. Closing wedge you can do without any bone graft. So here's a month and a half into my practice. This lady comes in. She's 46. She's got osteogenesis imperfecta. She's had multiple fractures prior in her life, and she presented to the Dotson Avenue Clinic, by the way, 5 days prior with this x-ray on the left. It doesn't project well, but she has a clear black line and an incomplete fracture, and she said, my thigh hurts, I think my leg's broken, I've been through this. And they said, well, just keep your weight off of it for a while, it'll be fine. And then 5 days later, she presented with this, and certainly has a deformed femur, altered proximal femoral anatomy, altered distal femoral anatomy. You can see that she has a second cora down closer to her knee. And so many people would say, this is impossible to nail this. We're going to use a plate, and it's going to be some weird plate contour. And hopefully we can get a plate to span the whole bone, protect the whole femur. Otherwise, we're going to be having a stress riser somewhere in the distal third of the femur with a plate. And so I made the plunge, maybe in stupidity, into attempted nailing of this. And so this is the first x-ray with on the left with the guide pin in. And so that should give you some concern about nailing this patient. We pressed forward. The patient essentially didn't have a canal proximally and right at the stress fracture site. So this is a finger device and a sharp guide pin going down into the distal segment across the first non-union or stress fracture site. And here's the ball tip when it gets down to the second deformity. You can see this is not going to be very successful down here for a nail. And so on the lateral view, we identified the apex of the deformity, and then with multiple drill holes and an osteotome made an osteotomy below, and then using a triangle, sort of did an opening wedge correction with sort of iatrogenic comminution, increased surface area. Ream with both reduced, and then fortunately we're able to sneak a nail in to her and get the entire bone sort of realigned and held stable. And so she came back at 6 months, no complaints in the right leg, otherwise I wouldn't have seen her, except for that her left leg hurt now, and she has a black line on her left leg. So fortunately we got to her left side before it broke and prophylactically nailed her left side. She's, as far as I know, doing well. I haven't seen her. She sort of disappeared after this. Dome osteotomy, this is another option. And so, again, we talked about the rules are the same, whether you cut outside of the cora or rotate outside of the cora. And so if the cora is very proximal, this is a useful technique on the right side. And so you can see our axis of rotation using the dome is still at the same side as the cora. So the proximal and distal axes realign. There will be some translation at the bone site, though. And so it's not a perfect realignment, but it gives you good bone contact and realigns the axis of the proximal and distal segments. This is the old McKay osteotomy above the tubercle. And you can see there's translation of the axes because the correction axis is not at the site of the cora.
Bryce,
Yes.
practically, how do you do that? At the one on the right, you're doing below the tibial tubercle.
Mm-hmm.
And how do you make? Do you have instrumentation to make the dome?
They do. They sell this. You can also, off the Smith & Nephew Ilazar offset, you can take a Rancho cube, which is this device on the bottom right. It's just a 4-hole cube. There's drill sleeves that go in it. And then you can fix it proximally and then rotate the Rancho cube and drill multiple holes, and it will drill along an arc. You can also freehand cut it, which is done, I think, a lot, and then use a curved osteotome to connect the points. And so this is not a true dome. It's a cylinder cut from front to back, essentially. And so this is the way I've seen described. They also sell this device that can be used that attaches to external fixator pin, and then it can center you, and you can drill. So if you want to use something fancier like that, that device is available. This is fixator assisted nailing, just briefly. And so it's using a dome osteotomy. And so in this patient example, this is from my fellowship. This is a distal femur with varus deformity. And so if you make the pin perpendicular or parallel to the knee joint, you can set the lateral distal femoral angle that you want. And so if you make this angle between the pin and this pin sort of the angle that you want for the lateral distal femoral angle, then you can go ahead and do the opening reamer, cut the bone, and then insert the nail. And when the nail engages the isthmus, it will realign the fracture if you've done everything correctly. I would encourage you to use blocking screws when you do this so that the bone just doesn't sort of crush the metaphyseal bone, or the rod doesn't crush the metaphyseal bone during the correction. And the frame can be used to help you if you set these pins up perpendicular to the mechanical axis, or perpendicular to the mechanical axis here, parallel to the knee joint here, and then eventually the pins will line up during your correction. The oblique plane osteotomy, we talk about this a fair amount. And so this is an osteotomy in the plane of that oblique plane that we talked about and showed you how to identify, and then the bone ends pivot through that plane. And so in fracture conference, Dr. Kiner showed a great example of this in the upper extremity. Essentially, the easiest way to do this is take fluoro and find the plane that looks like there's no deformity. And that's the plane that you're going to cut in. And that's... So on the AP, it'll look, say it's a varus deformity. On the AP, you'll see a maximum deformity. And then you're going to rotate until you get to some sort of lateral that looks like there's no deformity. And you're going to cut sort of obliquely like this through that deformity. And then the bone ends are going to pivot through that to correct it. And so you can actually put a screw or a wire in here and rotate around that axis and rotate the bone ends, and you get something like this. And there'll be bone that's sticking out on either side, and you can trim that down and plate it. So I have not done this, but I've seen it done in the upper extremity, for example. I'm sure my partners have done this before. Clamshell osteotomy, this is great for, a lot of times we'll have bad segmental injuries or injuries with a long segment deformity, where we try to figure out how we're going to realign this with a single osteotomy and make this work. And so this is the clamshell osteotomy. Essentially, you make a proximal cut above the most proximal aspect of the deformity and a distal cut below the most distal aspect of the deformity, and then use a nail to line those two segments up. And the way that you get it to go through the middle segment is you cut the middle segment longitudinally. Dr. Chandra here today? He's not. This is a patient, guy referred to me from Dr. Chandra, like all good things do. This is a patient, he was an Iraqi citizen that worked as a translator for the U.S. Army in the Iraq War in the last few years. Was in a car crash, had a severe open segmental tibia, treated in a cast or somewhat by an Iraqi surgeon. He had some sort of bone grafting from his right tibia to his left tibia, along with some sort of bone graft cement substitute. And so he presented to my office with this. His knee was hurting him. He said his feet were tripping up, and he just had daily pain with walking. And so he wanted to know what could be done. And so the question is, he's able to get his foot on the ground. Is this going to cause a problem? And so 5 degrees of coronal plane deformity has been shown to increase the risk of arthritis following an open tibia fracture, particularly in the varus plane. So this is examination of his deformity. You can see he has 14-degree varus deformity, 2 coras, and so you might be able to get away with 2 osteotomies and realignment. The question is, what's his canal going to be like? And I think the proximal segment too has a little bit of translational deformity. So we did a clamshell osteotomy on him. This is the start point. Fortunately, he was not infected. I went ahead and placed blocking screws to see if we could prevent the nail from crushing the cancellous bone during the correction. We made a proximal osteotomy. Drill holes. These drill holes for the middle segment and the tibia go parallel to the medial face of the tibia. So just posterior to the medial face, in line with it. And then longitudinal osteotome, and then osteotomy distally. He didn't have much of a canal, so used a sharp drill bit and hand reamer, and then reamed with the distal segment with a bone hook around the ball. The guide wire, excuse me. So reamed with it reduced, put in blocking screws. Unfortunately, he didn't need them. They were sort of a suggestion of blocking screws, but nonetheless, he had good deformity realignment with essentially 2 cuts and a longitudinal cut. We got pretty close. He was within a few degrees of his normal other side alignment, and he's very happy. So the key to all this is the plan, and to see what the deformity is going to look like when you're done, what the bone contact is going to look like when you're done. And so use all these steps to your advantage before you ever get to the operating room. And then this is him at final follow-up. Sorry it rotated, but as most videos do, he's walking very well, has no discomfort. And it's going real slow. Anyway, thank you very much for your time. A lot of information. Okay, good. Come on back. Any questions?